I would like to call upon stage the moderators for the panel on surgery for OSA, why, when and how. Moderated by Dr. Atul Pore.
Yeah.
I would like to call upon the panelists, Dr. Anand Raju.
I would like to call all the panelists to have the seats on the dais so that we can start and we can have a more academic thing. So the panel for today for an obstructive sleep apnea, when I ask Prasad sir what they want, so they want that surgery for OSA, why, when and how. So these are the three things that are come in everybody's mind. Everybody wants to do it, but how to do it, why to do it. The first question is why. I'll introduce all my panelists. They are esteemed panelists from all over the Maharashtra. But after this slide, so as Anand sir rightly said, first try. Partner going apnea. Oh, no, it's apnea or medical emergency. My partner is not there. Not knowing what's OSA. And then the apnea comes back. Patient is again hypopneic. So, it might be the situation, so you don't want to do it. So, that's why this panel is there. I have with me Dr. Anand Raju from Chennai. He is an eminent faculty in obstructive sleep apnea. Dr. Gajanan Kashid, he might join late because he is having his session. Dr. Nilesh Madkikar from Pune. Dr. Siddharth Yande is a senior consultant at Pune. Dr. Morarji Ghadge, he is also from Pune. Dr. Kaustubh Tambekar sir. I have included special maxillofacial surgeon to this panel. And Dr. Mangalmurti Chaudhari, he is an anesthetist from my team. He has been giving the anesthesia for all these odd patients since last 10 years. So let's start. Shall we start? Yeah. Now why OSA? The prevalence of OSA in Indian population. Now this study is being shown and it is done in AIMS. Can you realize what's the percentage? It is said that when they have done randomized sleep studies in a general population for a moderate obstructive sleep apnea, means obstructing at least 15 times in an hour, it came out to be 33%. That on a healthy individuals. That means 1/3 of every Indian, if we can reciprocate, or at least 20% of the Indians are suffering from obstructive sleep apnea, and they are going to have their effects. But still, there are very common dilemmas. These are some common myths, and that's why the panel is why and when to have these common myths go around. First thing, snoring indicates OSA. I would like to ask this question to Siddharth, whether it's true or not. Does every snorer is an obstructive sleep apneic or not?
Good morning, Atul. Thanks for this. Certainly, each snorer will not be sleep apneic.
Correct.
But having said that, we need to rule out sleep apnea in a patient who comes in with snoring. It may be by history, testing, whatever it is.
Exactly. So, what is the one key indicator?
If you ask me one question, it will be observed obstructive episode in
Exactly.
sleep.
So observed apnea means the partner says that he is choking at night. Patient is snoring and chokes at night. Alarm should be there. That is an obstructive sleep apnea. Next question to my friend Dr. Nilesh. OSA only affects overweight person.
Absolutely not. Basically.
Absolutely not. But 50% of the persons around this thing thinks that OSA only affects overweight. So it's not a person of, it's not a indication.
It's not only affecting, it's basically even the normal weight, even the lean and thin built are going to be affected by it.
Exactly.
So this whole myth of overweight people having sleep apnea it's completely out of the box now.
Now, as the science is progressing, we are seeing that it can affect any age, gender, and any body type. Obesity is just a risk factor, but people who are normal weight or even slightly underweight also can have obstructive sleep apnea. So it needs consideration in surgical mind. Sir, Anand sir, OSA is not serious. My father used to snore, choke. My 10 people around me are there. So it's not serious. Is it so?
No, it's not like that actually. Even first question, the only suppose lot of our individuals are sleeping alone. They can't find the choking effect.
Yeah.
So choking is one of the indicator of OSA. So simultaneously we need to ask little bit more questions about the daytime drowsiness.
Sleepiness and all these things.
Sleeping during drive, everything is there. So all 2 or 3 indicators. That's why we have a sleep and scale as well as Tom Bank criteria. Everything.
Exactly.
Is there. That's why OSA is always, so according to a sleep surgeon, is serious. So definitely it will affect the cognitive behavior and the daytime this thing and increase the BP and cardiac risk. It's always serious one.
So is it only serious according to the sleep surgeons or according to the all surgeons?
No. So all the public is definitely is a serious condition.
Yeah, so we need to see that it is untreated OSA leads to serious health issues. And now last, CPAP is the gold treatment. Morarji sir.
Certainly not, but we should start titrations done, try, but compliance, and if the surgical treatment is the standard where we can erase out the obstructive sleep apnea, we should go with the surgery. But there are certain cases where surgery alone may not affect, where CPAP can be the gold standard. But I would suggest that CPAP trial should be given to a patient prior taking to the surgery also.
Sullivan introduced the CPAP therapy in 1981. It is certainly said that it's the gold standard treatment, PAP therapy. It gives a continuous positive airway pressure to open up the airway. Then if it is true, then why we are here having a panel on surgical treatment? Diagnose obstructive sleep apnea, give a CPAP, and the job is easy. Yes or no?
No, the compliance of CPAP is very poor in our country, what we have seen even in the Western.
Why the compliance? The slides will come, yeah. Why the compliance is there.
Because
and then these things. Now see, this is a study. The question to the study has to be, should the use of 4 hours of only CPAP per night is to become considered as an acceptable compliance? I said no. Why? We sleep around 48 hours in a week. And only 20 hours per week using of CPAP will not reduce the cardiovascular mortality or morbidity that is being given with the help of use of CPAP. So it's not sufficient. Even if there are patients who are compliant, the risk because of OSA that is being there is not reduced. So we need some more thinking. And if you see a meta-analysis by this paper, this is around a long paper, 82 papers, meta inclusion exclusion criteria, and they said that the non-adherence of CPAP is, over the period of 20 years, is only people are 34% they are using the CPAP. Rest of the 2/3 population is not using the CPAP. Then the question is, why CPAP fails? Do you ever thought that's where the role of surgery comes? First is anatomical factor, second is phenotypical factors, third are some psychological factors. Now see, this is a road being blocked by a big stone. How to create or open that road? Answer simple, is to remove.
I'd like to add on the 4 hours of sleep that you already mentioned.
I cannot hear you. Just can you raise the voice, please?
With regards to the number of hours for compliance, the 4 hours is actually set by the American insurance companies. This is not a clinically proven thing. Besides that, they are coming up with studies now where to, as you mentioned, cardiovascular risks, but then to actually, even when you want to elevate the risks of diabetes, they are coming to almost 8 hours per night.
Exactly.
And so preferably, even if the patients are using a CPAP, it should always be advised throughout the night. 4 hours is not a criteria for this. The 4 hours is only been, given by the insurance companies who are actually giving CPAPs in the US and the UK. And they are, characterizing that as a compliance, which is absolutely, clinically it is not proven.
Clinically it is not proven, and clinically if this road is blocked, it has to be removed. So what are the anatomical factors? I have one. What are the static obstruction? This has already been told in Sir's lecture, so we'll fast forward. For static obstruction, treat the static obstruction and ask the patient to use the CPAP, because the CPAP pressure is high and patient becomes non-compliant. Dynamic obstructions, already been told in the drug-induced sleep endoscopy. We'll go ahead. Now I want to highlight the role of nodes for obstructive sleep apnea surgical treatment. We all know 50% of total airway flows from and the resistance in the upper airway is because of nodes. And this resistance is transmitted throughout the airway with the Sterling model that has already been shown. The first question before that, whenever there is a nose block, worsens it airway obstructions because of the hyoids and muscles attached to it goes down, posterior airway is blocked, it worsens the negative pressure and obstruction is worsened. First question, when are you going to do a nasal surgery? Any panelists, just give your thought.
So I would like to kind of add a small touch to this.
Yeah.
If the patient comes to your OPD and he complains of snoring and a nose obstruction is found out in your scopy, I would approach that slightly differently from a patient who comes into your OPD with nose blocking and say snoring.
Okay.
So if the primary symptom is nose blocking and the patient is not obviously very sleep apneic or not very heavy, I would want to correct the nose before maybe even
no,
doing
the thing is that it's a diagnosed sleep apnea.
If it's
you have done a DICE, you have done everything.
If the
you need a nasal surgery, and then the scenario is this: when are you going to do the nasal surgery? First thing, is it a stage procedure or is it a standalone procedure?
Given a choice, I would like to do the nose surgery even before you would want to try a CPAP if the nose is very, very bad. Secondly, if surgery is being contemplated, I would like to combine it with, if not anything else, at least a DICE, so I know what is happening underneath to plan the next treatment in case the patient wants something.
Okay.
Thirdly, the question here arises is that if, and as in my practice, I would give a patient a titration option before going ahead with surgery many times.
Exactly, that is being done.
Correct. In that case, if the patient is very happy and there is no complaints of nose blocking, we may not want to touch the nose. But if the pressures are high, patient is not happy, then obviously, and I think that is one of the most impactful surgeries is to do the nose surgery.
Exactly.
Yeah.
Sir,
I will
in your
actually,
practice?
Yeah. So, so I always do multi-level surgery in single stage. So this CPAP. So we know actually CPAP complaints is very less. Suppose you are a patient, suppose I advise CPAP for lifelong, do you accept? Yes or no?
No.
No one accepts CPAP. So pulmonologists, they do a lot of sleep study. Straight away they are prescribing CPAP. So this is a multidisciplinary team. They have to refer the patient to ENT to assess the upper airway collapse. Then it's a teamwork actually. So if there is a patient that have only very minimal obstruction, definitely CPAP is work actually. Otherwise CPAPs don't work. So it's a nasal surgery. It's a part of the sleep multi-level surgery. I do sleep surgery along with the nose. Always we would address the nose in sleep surgery. First nose, then palate, then hypopharynx, everything all in single stage in multi-level surgery.
So you do all single stage.
Single stage.
Any difference in opinion of the panelist? Nasal surgery standalone, diagnosed OSA, you know obstructions are there. Patient given a preference, doc, my risk taking capacity is not there. I want to do this first. Let's stop and do the second, or what's this? Give the mic to him, which is working.
Yeah. So as far as I am concerned in my practice, after the DICE, if I've decided to do a surgery, it will be the nose and the palate.
So you do a nose and palate simultaneously.
Yes.
Any difference of opinion? Morarji?
I do standalone both together. when it
Okay,
is
so you do a nasal surgery
nasal
first.
surgery first and
Then do a CPAP
so-
titration, wait, do a dice, and then again. So that can be one of the ways. Next question that is always asked, only doc doing a nasal surgery, will it cure my obstructive sleep apnea? Yes.
Absolutely. No.
Anyone pick up this and give
No,
answer?
it will not, and this is where the initial discussion that we have with the patient matters, that no, it is not curative. What is the role of your surgery? Is it to make the CPAP use easy? It is a part of a plan to cure sleep apnea. So this is all the counseling that we do before you start on the route of surgery.
Does the age of the patient and the comorbidities have some role here?
Absolutely.
So I want to you just address to the, if it's a young fit patient and it's a old age lady or something like that.
Very old age you would like to avoid surgery anyways. But
Yeah.
coming back to the point of age, young patient, less BMI, the probability of giving a good result is higher. But I would not ever guarantee saying that your OSA will be cured only
So
with
that's the word. There is nothing called as a guarantee, or rather it has been shown that with the help of nasal surgery, the snoring sometimes increase in the patient. So they may feel that even if the AHI is reduced, the snoring is in.
There is something interesting, just one point. Sometimes if you open up the nose and the breathing improves, patient may go in more of deep sleep, leading to a higher AHI on a repeat PSG done later
Also,
on.
there is one paper from our friend Dr. Shailesh. He has done a study over around 100 individuals, where he has done a standalone nasal procedures followed by these things. He has found that the pattern of collapses changes after the nasal surgery. So these are two things. The next question is one of the most important part of OSA surgery is anesthesia. Everybody is scared of. Surgeons are more scared of. Dr. Mangalmurti, I want to ask you a specific only for the nasal surgery in OSA. What is your anesthesia consideration? And how we go ahead for the nasal surgery? How it's different from a routine nasal surgery? I'm not talking about a complete multi-level or a staged nose plus palate. It's just a standalone. Doc said, I want to do a septoplasty, turbinoplasty, that's it. But this is an OSA patient, that's it. Now tell me.
Routine nasal surgery versus nasal surgery in OSA patient.
Yeah.
This OSA patient, we need to consider them as these patients as a different patient. We usually say OSA means difficult airway. Usually, many of anesthetic are not trained to give anesthesia, deliver anesthesia to OSA patients, so they find it difficult. So, in OSA patients, if we clinically, if we do proper assessment, clinical assessment in OSA patient, proper airway assessment, then individual systematic assessment, if any hypertension or other systematic effects of OSA is there, that correction, then
See, intubation is okay, but when the nose is packed and the patient is coming out, that's what the point is more important. So what
Yes.
you advocate or what we practice,
Yes.
what is your routine practice? Do you
We-
tell the surgeon not to pack the nose? There are some surgeons who don't do this, there are some surgeons. So what additional precaution that you do?
we routinely counsel patient prior to surgery in pre-op room that your nose will be packed, and we advocate them to practice breathing while nose is closed, so patient is comfortable post-op with packed nose. This is one thing.
Awake extubation,
And
anything like that?
another point I want to add, during mask ventilation, before intubation we do mask ventilation. In mask ventilation, when there is a DNS or nasal obstruction, so patient will not, our oxygen will not go through the nose. So we need to keep mouth open, or we need to put oral airway for mask ventilation. That is very essential. Otherwise, we cannot ventilate the patient without airway or keeping mouth open.
Okay. So that means with the safety precautions, with the time of extubation, these things and awake extubation, you can go ahead with even
Yes.
if it's a standalone procedure. for practicing it all, even all small nursing setups also.
Yes, yes.
Any point to add from this panelist?
As far as the nasal surgery is concerned, I think so in an OSA patient.
In an OSA patient, this is all.
Even if you're doing it as a standalone procedure, I have stopped packing the nose completely.
Exactly. So this is one good point.
It is basically nasal splints, silicone splints, and if required, keep a nasopharyngeal airway till the patient is completely out of anesthesia.
There's a fantastic
That-
point
that is
raised.
more
Keep a
than enough.
nasopharyngeal airway ready. Anand sir, your point, anything?
No, you know that actually, so we'll lesser use some muscle relaxant during extubation. Actually, it's very important. Awake extubation. Sometime actually we have to extubate in a slow motion. Actually, that sudden desaturation is very common during extubation. That's why we prepare, if needed, we have to intubate again, and we give a little propofol and ask the patient to little sedate and so extubate slowly. So I agree with Nilesh. So we won't pack the nose. Sometimes it's a multi-level surgery, we won't pack the nose. So in standalone practice, like normal phase, but in severe OSA patient, definitely we won't pack almost 90% of the cases.
Modality of choice for treating the turbinates. 1 point from each consultant. To treat turbinate, what is your preference? How do you deal with the turbinate?
Turbinectomy.
Turbinectomy. Partial turbinectomy, total turbinectomy.
Whatever. I don't.
Whatever.
Whatever. You just
So,
turbinectomy. Partial means just trimming something. No, you will do
Okay.
a significant removal. But
so the posterior
turbinectomy
part
is,
that you remove, anterior part is being
throughout,
kept
parallel
throughout the
to-
part.
yeah.
Yeah.
No, it's a partial turbinectomy. It's a very minimal with the grass DNS. I do a channeling and deviated septal surgery. But
So-
turbinate alone is a
Exactly.
turbinectomy.
So you have to treat the DNS, high DNS also be done. Nilesh, anything to be done for the middle turbinate?
I strictly don't believe in that. But if a concha is present, yes, I will go in for a middle turbinate.
Okay.
As far as the inferior turbinate is concerned, I've always stuck to radio frequency and then fracture and lateralization.
So your choice is radio frequency
Radio
rather than a
frequency.
cutting.
Yes.
Does anyone have an coblation for this? Have
I
you
do
any experience?
coagulation also.
So what's your experience? What is better suits that in your
The
hands?
coagulation means I don't use a turbinector wand actually. I use a UVAC 70 wand to ablate as well as little push the fracture of that bone. I do lot of channeling of a turbinate. Suppose the turbinate is not a huge one, but I do channeling for all case along with the septal surgery.
So the message that we want to give here is everyone start doing at least nasal surgery in OSA patients. Do a proper nasal septal surgery, turbinate reduction, and if there are concas and something, then do a touch to the middle turbinate. Now this is a
Just a point. I would say basically the turbinates need to be addressed in every patient.
exactly,
Period.
yeah.
Even if you are doing a very limited septoplasty, the turbinates have to be addressed as far as OSA is concerned, as well as any other nasal surgeries.
Now, this is a case, just to tell, AHI 36, grade 4 tonsils, not ready to undergo any sleep study. Will you give a CPAP to this patient?
Definitely no.
No?
Interesting point here is that if he has a AHI of, if he has a AHI of 36,
36.
and he doesn't want to do anything, we have to do something. This is a theoretical discussion. We would obviously like to remove it. There's no question about it. Looking
So
at
would
this,
you give him a CPAP?
I don't know whether I will try my best to tell
You see
him.
this picture?
No, I will certainly not give him a CPAP. There is no
Okay.
question about that. But the other point of discussion for not only this, but overall is that if a patient is not willing for surgery or not suitable for surgery or
No, he is not willing for this PAP.
he's not
No,
willing.
and he said that, doc, you give me a one solution. You seen that?
No, first, you have to remove that.
You have to remove.
You have to
So
remove
these are the static obstructions. The point is static obstructions to be removed, and then these adenoids in a 42-year female also we can get for obstructive sleep apnea the adenoids. Dynamic obstructions, modalities of dynamic obstructions. Clinically, how you judge for dynamic obstructions? Anand sir?
No, clinically means is outpatient clinic or so
On
normally
clinical. do you do NPL in for any every patient and Muller's maneuver?
Yeah, normally in outpatient clinic I do a flexible nasopharyngoscope
Yeah.
and do the Muller's maneuver. So there is a literature now, even Muller's maneuver won't give a proper assessment of collapse actually. Some patient they not able to do a Muller's maneuver properly. So my thing is I ask them to do a Muller's maneuver, but with Muller's maneuver alone I won't decide whether it's a severe obstruction or this
So
one.
that's the first thing to get to know about
Yeah,
the patient.
Yeah, yes.
Nilesh, what's in your practice? Do you do NPL in every case?
As far as NPL is concerned, not usually on the first consultation.
Okay.
The way I approach any OSA patient, the patient has to go, now that's for me, a level 2 sleep study,
And then
irrespective.
a drug-induced sleep endoscopy if he wants to undergo a
If-
surgical treatment.
Depending on what the sleep study shows us.
Okay.
If it is purely obstructive, a lot of obstructive with mixed, yes.
We are discussing only
Only
about
OSA.
pure obstructive sleep apnea coming to an ENT surgeon.
But then, again, even for medical legal purposes, please keep in mind that a sleep study needs to be
Nilesh,
done.
the question is already sleep study done, so they are coming for sleep apnea treatment to
Sleep
you.
apnea treatment, more of a surgical treatment. So we
Goes
are
for a
inclining
DICE.
towards that.
He goes for a DICE irrespective.
DICE is your.
Yes.
Everybody agrees about the DICE. I will not go into detail about that because that has already been in detail been said. Any word on dynamic MRI? Anybody uses
So,
his experience?
we tried to do that,
Yeah.
and at the institute level, and it is much easier said than done, because getting the patient there, he's sleeping at that time, you getting the recording, there are many ifs and buts, and at the end of the day the visual impression of a DICE is, according to me, far more superior and information giving to me. Now
Okay.
everybody may have their own opinion, but if I have to choose one, then I will certainly choose a DICE.
So my thing is, I sometimes like dynamic MRI in a lot of cases really this thing. Some patient they want to agree for DICE straight away for even small anesthesia, as well as the dynamic MRI. Sometimes actually we have to give a little sedation for to avoid the noise pollution. The patient sometimes they won't sleep in MRI this thing. But it will assess the whole sleep actually. Even the REM sleep, we can get the clear picture of collapse in dynamic MRI. Dynamic MRI also is a useful tool to assess along with the DICE.
So we tried to give this as a thesis to one of the radiologists. The problem with going to REM is the patient has to be there for that long, and it has to be objectively verified, which is very difficult. And keeping the gantry occupied for that long and all
So it is
those
technically very difficult.
to
That's why
get
all
that,
dynamic
yeah,
MRI
yeah.
they used to do in the late night with no appointment. So it takes at least minimum 4 hours
4
or 3
5
hours sometimes.
So it's difficult.
DICE is being discussed. The question only for this is to the anesthetist. Anesthesia consideration for this procedure. 3 points that everybody should take home, like these are the things you take home. Drugs used, your preferable choice, and what you should be ready with. And third, do you say BIS is must or not? Yeah.
Drug use are, as per literature, propofol, midazolam and dexmedetomidine. We routinely use dexmedetomidine because it mimics natural sleep. As an anesthesiologist, we need to be very patient. At least it needs 10 to 20 minutes to sleep properly. Room should be total darkness in room. Monitor sound should be stopped. Then after proper preparation and when patient sleeps, means we need not to induce very deeper level of anesthesia. If BIS monitor is there, BIS monitor should show figures between 50 to 70, 60 to 70, 60 to 80. We can do sleep study without BIS monitor.
Do you
When
see sleep study in each and every patient before going to the DICE, and what it gives idea for you?
Yes.
Lowest saturation that you see, number of AHIs, number of apneas. As an anesthetic point of view, you also see a polysomnography report before taking the patient to the DICE. That's a good thing that he
Yes, yes.
practices.
We
That's what
usually-
point I want to say.
Yes, matlab it is mandatory to completely evaluate sleep study. What is the lowest saturation we should be know, and most of anesthetic fears to the saturation dropping saturation. If patients having lowest saturation 75, 60, 80, then as a matlab, being ENT surgeon, you need to tell your anesthesiologist that this is a normal saturation in sleep, so you need not to panic when saturation will go
But
down.
be ready with that.
But be
When you
ready,
say
yeah,
be
yeah.
ready with all the
Always be ready for intubation and all gadget. What is most importantly needed is nasal airway, proper size of nasal airway. We need to
Very
measure
nice. So,
that.
nasopharyngeal airway is the one thing that everybody starts having in his OT before doing even for any nasal surgery, ear surgery. It's a good tool. Doc, when you say no, straight away no
For dye surgery.
for DICE or any surgical intervention.
There are 4 or 5 things. One is upper respiratory tract infection, lower respiratory tract infection. Then patient is active smoker. Then he is having COPD or asthma which is not controlled. When OT setup is infrastructure and setup is not good, best quality, means there should be a difficult airway cart, proper monitoring and workstation. All these things should be there. This monitor is not mandatory, but basic monitoring, difficult airway cart and ventilator, intubation, all that things should be there.
Do you think a post-op ventilatory system has to be a mandatory thing when you do a nose palate? I'm not talking about nose palate and tongue base. I'm talking about nose and a simple palate surgery. Is it a must for everybody to have a ventilatory setup?
No.
And if yes, in which special situations?
Yes. If patient is having severe OSA and if he is already using nasal CPAP, then same nasal CPAP should be continued in post-operative room. Otherwise, in many of patients, if you are going to do nasal and palate surgery, only basic monitoring, oxygen, propped up bed, this is mandatory.
Extubation or intubation, what matters most for you?
Always extubation, because just like अभिमन्यु चक्रव्यूह में जाना easy है, तो extubation में we need to be always propped up position, then awake extubation that should be
You
tried.
try to extubate the patient in an awake situation rather
Yes,
than
yes.
a sedated thing.
Completely awake. And one more point is always use oral or nasal airway while extubating. That is very safe, because patient, when we extubate this patient, they are very wide awake, and within next 2 to 3 minutes or 5 minutes they will again sleep and start snoring. So for next 2 to 3 hours post extubation are very important. So we need to monitor them in recovery room.
What about the blood pressure maintenance at the time of extubation? Because these are the small things that matter for every surgeon.
Yes.
Because that will give a result different and the complications are more. So what do you do to maintain the blood pressure at the time of extubation?
Yes. Patient, if we want to normalize the blood pressure, many a time when patient are widely awake, the blood pressure is very high. So I used to extubate patient in light sedation. Before extubation, I always put nasal or oral airway. But extubating patient in light sedation is a somewhat skilled work. So in initial practice, we should always do awake extubation.
With any additional drugs?
Don't try for blood pressure normalizing. When you are skilled enough, after 1 to 2 years, then you can try for extubation in sedated patients.
Any special instruments that you want?
Yes. Always in books they mention that you should have fiber optic scope, video laryngoscope, but what is important is the skilled anesthesiologist who is used to which instrument. I am used to direct laryngoscope with McCoy or Trupti blade, 4-number blade, and that is sufficient if you are comfortable and routinely doing that. If you are directly going for true view or video laryngoscope and you are not used to, then you will end up in difficulty. So basic laryngoscope with McCoy Trupti blade, then bougie,
ventilating bougie is an additional
nasal oral airway, and multiparamonitor with capnograph. That is essential. In DICE also we should monitor compulsory SpO2 and capnography. And respiration. Most of anesthesiologists don't switch on respiration, means don't enable respiration in the monitor. Most of 4 para or 5 para monitor does have respiration, and when patient goes in apnea, we can see on monitor.
About that. A word from an expert, a dialogue between a surgeon and anesthesia for OSA. What's the role and what you're doing with your regular anesthetists, but the dialogue, how you have developed? Because that's one thing that juniors needs to take up.
Yes. What is essential is...
No, I have this question to Anand sir, and from a surgeon's point of view, your dialogue to your anesthetist.
That's why almost I agree with him actually. So always, so all patients coming from anesthesia, they're very wild actually. So I used to tell my anesthetist, give a little propofol. Always my anesthetist is actually, we are doing a sleep surgery for more than 15 years. So with mild sedation, I will give a propofol during extubation. With mild sedation, always the BP is a little low, we will extubate. So adding to this thing, so we will keep a laryngeal mask airway also
Fantastic.
nearby.
So that's one
there
thing.
is very difficult to intubate sometimes. Actually, we'll put a laryngeal mask straight away, the patient will be safe. So I agree with almost he covered all the points, so I agree with him. Okay.
Your point of view, Nilesh? Anything to add?
I stick to only one anesthetist.
Okay.
That is one.
If it is not available, then
postpone it.
that's the simple.
Period. No doubt.
Now, we'll be little faster for the next few slides because we have just 5-7 minutes left.
Another thing I would just like to add is that don't try hypotensive anesthesia when you're doing palate, nose or multi-level. Try to keep it to normotensive or the pre-op BP, whatever was there, so that on table you have an idea about everything that's going on. Because in these kind of patients, once you've operated them and once the edema sets in, you're not going to be able to intubate these patients. It's going to be very difficult. If you've done palatal work, your palatal work is going to be destroyed. And in those instances, as I said, the laryngeal mask needs to be on the trolley irrespective.
Fantastic.
So not only the oral and the nasopharyngeal airway, but the laryngeal mask is equally important.
So points that decides the palatal surgery is about counseling, expectation versus reality. One point from each one of you.
So already everything is there. So the palatal, the proper dice. So assess the level of collapse and severity of collapse and pattern of collapse. So the selection of surgical mode is very important. Whether you do a antipalatoplasty, expansion or bobbed or anything actually. Single stage, multi-stage is according to the surgeon actually. Suppose comorbidity is more, you can stage this surgery. Otherwise, a single stage and multi-level surgery. So all this depends upon the surgeon. So
any contraindication for palatal surgery where the low of skeletal surgery is there? Now I will introduce our maxillofacial surgeon from here onwards. Contraindication for palatal surgery.
Hello. So basically, I'm a sort of odd man out here.
No sir, you are not the odd man. You are the resuscitator for us. If nothing worse, then you were.
And probably even palatal surgery is not my keen area, but I deal with actually maxillomandibular advancements, and particularly patients who are having some skeletal malformations, maybe congenital, for example, TMJ ankylosis and mandibular hypoplasia.
We have only last 3 minutes left for us. So a complete concentric collapse, then the role of skeletal is barb or not for use of all this.
Sir, is this the last slide?
Nilesh is the only person doing a lot of bob.
Because we are already half hour late, as I have been told. So we'll just wrap it up.
One thing that if you are going to operate the palate,
I'm just 39
I would say barb is working excellent. And it addresses equally the anterior posterior as well as the lateral collapses as well as the concentric collapses. So in my hands, I would say barb all the way.
So it's a game changer.
Yes,
It's a reproducible thing in everyone's hand.
Absolutely.
So try,
Absolutely.
everyone
And it's
start
very
trying
easy.
the barb.
It's, any ENT surgeon who's been doing tonsils can easily manage a Barbie, with a tonsil.
No,
Yeah.
so the selection is also important. Suppose it's a huge uvula and very thick
Thick palate is-
palatopharyngeal muscle. I think
it doesn't
actually.
work.
Yeah. So selection is also important.
Percentage of patients in a multi-level surgery you come across for the tongue base collapses in everyone's practice.
Yeah.
Sir, you?
It's me?
Yeah.
Multi-level collapse is almost 80%. In tongue base, actually surprisingly is more than 40%. So my opinion is tongue base in all severe OSA, tongue base is collapsing.
Okay.
So my experience is always address tongue base in severe collapse.
Nilesh?
As far as tongue base, luckily in my practice I don't have too much tongue base, so I'm relatively safer. But then if at all the tongue needs to be touched, it's going to be at a very later stage. I will always go in for the nose and the palate first, wait for at least 6 to 8 months. Most of the times with the Bonalli's phenomena acting in, the
Fat
hypopharynx.
reduction, CPAP use?
Absolutely.
you or not?
Always give a trial for CPAP when it comes to tongue base.
Sir?
Absolutely, and even the advancement appliances can be tried. before
Fantastic.
that
So
is
this can
something
be an additional thing. You do a nose palate work, you can give an mandibular advancement for the dealing with the lower this tongue base collapses. Skeletal surgeries.
I'll say whenever it's been encountered or done, it is technically 100% success.
Exactly.
So it is that radical, and many times in the initial days, just to share you, in 2003 my thesis topic was obstructive sleep apnea and its role in TMJ ankylosis and management by doing distraction osteosynthesis in mandible. So basically mandibular hyperplasia.
So the point is we need to find out one good maxillofacial surgeon with us to practice an OSA. Sir, how many of MMAs that right now you are doing for the OSA?
MMA actually I'm still not doing basically for OSA, but I'm doing for skeletal deficiencies. So
Okay.
basically people are actually demanding that surgery because of their dental issues and their aesthetics. So they are coming for that, but they are getting treated actually for OSA too as a bonus.
So as per Stanford criteria, it's a level 2, means once you are all the soft tissue surgery doesn't work, then you go for a skeletal surgery. But for any rhinognatic or for an anthropometry, the first line of management still that we say is an MMA, given a choice and after your counseling. These are a few of the patients. 6 key messages from every panelist, starting from sir.
So, my first talk is I gave all the ideas. So, assess the patient, do a proper dice, and concentrate a little bit on dice. Actually, at least do a dice for 20 minutes. Assess the
So
area.
that everyone starts practicing surgical.
Yeah. And actually, our anesthetist I think scare you most actually, but there's nothing to worry. So no ventilator is necessary, but proper post-operative ICU is little bit necessary. So actually, address the nose first. Always address the nose first. So nose is very important. This thing. So Starling's law. We go to reduce the nasal resistance. Definitely, we improve the upper airway. Then concentrate a little bit in the palate and concentrate in the tongue base. So see a patient as a whole, assess all the area, do a proper dice. Definitely, you will master the surgery. Thank you.
Golden words. Mangal sir. One message.
Proper assessment of the patient, surgeon and anesthesiologist proper planning before doing surgery, means regarding intubation, extubation plan, post-op room, surgical steps, that is important.
So it is the confidence between you and the
Yes.
surgeon
Yes.
that makes the OSA surgery simpler.
Yes, and
Morarji sir.
I think proper communication with the patient regarding your treatment protocol.
Exactly.
which is very much
Expectation
important.
versus reality.
Yeah.
You
Because-
have to tell what you can do and what you want to
Yeah.
do.
That is very much important because patient expect a lot at the same time, but we have to deliver to their
Fantastic.
expectations what they want.
Fantastic.
Yeah.
Along with the surgical treatment, any other thing that you want to add, sir? Next.
Don't go with a fixed idea of you will do A, B, and C. You have
Wow.
to tighter the plan as per the patient's.
One size doesn't fit all.
all.
So it's a custom-made, tailored approach. Nilesh?
One thing is that don't guarantee anything. at the same time, you as well as the patient need to be very well informed about each and every alternative therapy that is available.
Exactly.
It
Along with
has
the
to
surgical
be-
treatment, there are
has
other
to be told to
modalities
the
that has to
patient.
be practiced. And our
Yeah, as a maxillofacial surgeon, is the best person to actually give you a different view as far as OSA is concerned. And if you can involve in your treatment planning, it will create miracles. That's my personal assurance.
So I end this panel with saying, make no mistake about sleep apnea. He is a grim reaper. He just lets his friends put their name on death certificate. And we are there in between. So start everybody practicing sleep surgeries for OSA. Thank you very much for all my panelists for giving their inputs. And thank you audience for the kind listening. Thank you.
Thank you, sir. I would like to call upon stage Dr. Premchand Malpani, our chairperson, to felicitate Dr. Anand Raju for his talk. I would also like, sir, to felicitate Dr. Atul Pore for his lecture.
All the panelists first. Let I have all the panelists.
I would like to call upon stage Dr. Pratik Parma to felicitate the panelists, Dr. Anand Raju, Dr. Nilesh Madkikar, Dr. Gajanan Kashid, Dr. Siddharth Yande, Dr. Morarji Ghadge, Dr. Kaustubh Tambekar and Dr. Mangalmurti Chaudhari. I would like Dr. Premchandra Malpani sir to felicitate Dr. Atul Pore who moderated the session. I would also like to call upon stage Dr. Dhananjay Kulkarni to felicitate the chairpersons. Our next session is a symposium on silent endoscopy, unlocking salivary solutions, discover the future of silent endoscopy. I would like to call upon stage Dr. Shirish Ghan sir, Dr. Umesh Torne and Dr. Mahesh Nikam.